Welcome to Cracking Consciousness, the podcast where we crack open mysteries of the mind, one layer at a time. Delving into questions about neuroscience, technology, and mindfulness, we aim to simplify the brain and mind, providing fascinating facts and sharing actionable tips for you to connect with others and experience life. We often feature experts and community members to share their lived experiences and knowledge. Today, I'm thrilled to be speaking with Dr. Linn Harrison, a physician, writer, and force in the field of narrative medicine. Dr. Harrison, thank you so much for being with us today.
Of course, it's my pleasure.
So I want to start with stories. Stories are told all around the world, each and every day. We know that cultures have told stories for a long time. We first saw this in cave paintings in Lascaux, France, and Chauveau, France. And again, this dates back to 30,000 years ago. They often depicted animals, humans, and even other objects. And today, we're all consumers of stories, whether it be heated debates on Twitter, getting advice from our parents, or even workplace disagreements. We all do it. Dr. Harrison, my question for you is, you've been writing and creating stories for a while now. What gets you excited about stories, whether it be creating them out loud with patients, in your head, or on paper?
Well, for me, expressing something in words creates really a new understanding. Robert Frost once described a poem as a clarification of life, which is a quote I really like. And I think writing offers a way to enter more deeply into our own experience, but also listening to a story can expand our understanding of the experiences and perspectives of others who are very different from us. And it can also reveal new possibilities and choices for living your own life. So there's a lot of richness that I find in stories, whatever form they come in.
That's so interesting. I think the quote, clarification of life, is so meaningful, and we'll see, especially as we talk more about narrative medicine, how that plays out in the medical world. So let's start by grounding ourselves in what narrative medicine is all about. How would you describe narrative medicine in a few words, and why do you think it's gaining more attention nowadays?
I think it would be helpful to just give a little background summary of how it evolved, which I'll try to do succinctly for you. What we think of as narrative medicine really originated at Columbia University, the work of initially Rita Sharon and then many others there. Mm-hmm. And that program has been ongoing since the year 2000, and that's the year that she published a description of the concepts. And it really focused on analysis of literary texts. The specifics of narrative medicine uses literature, close reading, and now other forms of narrative, which is a technique derived from literary criticism, actually, and Dr. Sharon has a PhD in 19th century literature. So you do close reading, which is really analyzing not just the content, but also the structure of a text to see how that enhances meaning, and then reflective writing to a related theme, which is sometimes referred to as writing in the shadow of the text. And the objective, as she described it, was to bring something she defines as narrative competence to the practice of medicine. But there were some precursors some independent streams that I think have now joined with what we think of broadly as narrative medicine today. One was medical humanities, which is really a 30,000-foot view that really looks at health and medicine in the context of social, cultural, historical forces, mm-hmm. not so much as much the individual. And Penn State University has been a leader in this, and they established a humanities department at their medical school in 1967. It was the first one. Joanne Troutman Banks was instrumental in that. And then, interestingly, there's a parallel effort in visual arts and visual analysis, and that actually was independently brought into medicine through the Department of Dermatology at Yale, where they mm-hmm. had students or residents look at pictures to help them get better at looking at lesions. Mm-hmm. So, but applying these techniques in a patient encounter really enhances communication and leads to a greater affiliation, a connection that develops between the doctor and the patient or the healthcare team, because they achieve a shared understanding in their communication. So that's a short version, and we'll talk more about some of the details. And why it's getting more attention now? I thought that was a really interesting question. And thinking about it, I think shared stories create communities. I mean, that's really one of their larger functions that we can discuss a bit later, perhaps.
Exactly, yeah, and that's what I was just wanted to transition to. I was watching one of her TED Talks, and she was discussing how from the moment you enter the room with a patient, there's all these clues that are looking at you, how they're sitting with their family, what they might be communicating, like they're gazing, the intonations and different things that they say. And then, of course, back to the medical side, you look at their chart, their past medical history and all of that. And it's kind of combining everything and then going from there and seeing how you can help that person and how you can help them contextualize what is going on and how they can help you understand what's going on with them. And I think that's a great way to use that skill. Now, we've kind of laid out what narratives are, the evolution of stories, and I want to transition into more of how narrative medicine is used in practice, serving its original intent. And the way I see it is that there are two main avenues that this is kind of done through. First is the way you connect and care for patients, and then the second is also revolutionizing training to be more humanities focused and more empathy focused. And I want to start off with the former. How would you say narrative medicine helps patients contextualize their illness and help clinicians understand existing narratives in a patient's life?
One of my colleagues in neurology is Dr. Sneha Mantri, who was actually is a neurologist as well. Mm-hmm. And she's been working specifically using narrative medicine strategies with patients with Parkinson's disease. And I like the way she describes this as saying that narrative medicine offers a way to listen deeply to the stories of those living with chronic illness and may inform our health interventions to reflect really creating those that are going to work best for that individual patient. So that's from the physician's point of view. And as you were just describing, the observation skills that we bring to the encounter that Dr. Sharon described as well as anybody could in the quotes that you were using, really helps us recognize verbal and nonverbal elements and give us a sense of where we need to explore something that might lead us to a deeper understanding of their narrative. And one example that I've seen is patients switching sometimes to the third person. It's a little disconcerting when it happens, where they're describing the illness as it affects them, and suddenly they'll switch to the third person. Mm-hmm. And so clearly it was such an alien experience. It's almost like it was happening to someone else. Mm-hmm. So just asking, what that was like for you. It sounds as though it was almost like it was happening to someone else, and get some understanding of what the significance of that change was, mm-hmm. and how that will lead you into better understanding them.
It almost sounds like that's trying to distance yourself from something that you don't want to think about, or you just want to forget, or you don't even realize it happened to you, maybe.
Yeah. So there could be, and that's sort of a trauma response often. And then so if you do identify a narrative, then that gives you an opportunity to explore alternate narratives. Mm-hmm. And it overlaps, and Dr. Mantri makes this point, it overlaps really with some of the communication skills of palliative care. They use a different terminology, like what's the patient agenda, what's your agenda, but those are mm-hmm. the two narratives on some level. Those
and can we just define palliative care is?
Absolutely, yes. So palliative care is a set of management strategies, but communication strategies that really broaden the hospice approach. So it's really people who are living typically with disorders that can't be cured. It's not necessarily the very end of life that we think of hospice care, but it's really people facing an illness for which there's not going to be an ultimate resolution. And so helping people identify priorities, manage the emotions associated with the illness. There's several different systems of training to communicate around those difficult issues, mm-hmm. and create a new plan going forward, which has pretty obvious correspondence to creating a new narrative for yourself. This is what I can do now.
Mm-hmm. Sure. Yeah. And I want to move on to the idea of illness narratives, which we touched on a little bit. I know that Arthur Frank, a sociologist, was kind of the pioneer in illness narratives, but can you clarify what illness narratives are? And maybe share any stories that you have from patient interactions where you were able to kind of pinpoint something and then move forward based on what you learned.
Sure. It's a very, very powerful concept in medicine and elsewhere, as we might have a chance to discuss. But his seminal work was called The Wounded, and it's an account of his own experience with an illness when he was relatively young, at age 28. And so he talks about really three archetypal narratives. Mm-hmm. A quest, which is seeking something, a particular outcome, whatever it may be. Restitution, which would be a complete resolution of the problem, which is always not always obviously available in medicine. But then there's what he terms chaos narratives, which really are disorganized, unpredictable, lack structure, and are very difficult to navigate for the individual experiencing them. For any of them, though, I think one of the goals of narrative medicine, if we're, again, using communication tools and recognizing these narratives, then we can help the patient create a new narrative that preserves the meaning of their life, even though their life is going to be different or going to be shortened in the face of the illness that they're undergoing. So I think I've described the types of narrative. So you have to be alert again for those clues. But I think the first step is recognizing that you and the patient may not be talking about the same thing. I mean, that's essentially what you have, a different narrative. You have a certain idea what's supposed to be happening, how this is supposed to play out, just the narrative of that little encounter, if you will.
Sure.
And the patient has different expectations. So the anecdote that I think about relatively often is a patient that I saw when I was in my training, and I had admitted and taken care of for a stroke. And he had left-sided weakness and went to rehab, and I was seeing him back for the first time. And so I said, Mr. So-and-so, it's great to see you walk in. How are you doing? How do you think your weakness is better? Oh, yeah, doc, my weakness is a lot better, but my stomach is killing me. And we more or less went around that same path for a few more minutes, where I'd say, so you're able to get in the shower, you're able to feed yourself, no problems. No, I'm fine with those things, but my stomach really hurts. So finally, it took me longer than it probably should have. I was like, okay, sounds like the stroke's not the issue here. Yeah. Tell me about your stomach. And and he had some concerning symptoms, so I ordered some testing, and he had colon cancer. And if I had just stuck to my agenda, I would have missed that opportunity to diagnose his colon cancer, which is not what I was planning to do as the neurology resident.
Of course. Yeah.
So
super meaningful.
Yeah, so it was. Well, it was a good lesson.
Yeah, and that's interesting. I've also noticed that I've been a medical assistant in an ophthalmology office over the past few months, and it's been so great learning from patients and, of course, about different conditions, but also their stories. And they've shared like so many tidbits of things that take you back to the idea of zooming out. Like it's not just what's on the paper. It's not just dry eye syndrome or double vision. It's like what is going on with them and how can you help overall? Because again, this is what really the idea of narrative medicine, zooming out and being able to understand as much as you can from them and vice versa.
And using all the information that you're given. And that's just going back to that description of sort of from the minute you walk in the room, from the TED Talk. And Dr. Sharon actually has developed an exercise called the parallel chart, where you write down, you describe an encounter and you put down all the things the chart leaves out. The interactions, that everything about what happens there that helps you understand what that patient's experiencing beyond their symptoms.
Yeah, definitely. So circling back to narrative medicine's impact on medical education, what have you seen in the system? I know you're also involved in helping create those curriculums for neurology residents. So can you share a little bit about the evolution, or I guess what you're seeing right now within the last few years about narrative medicine being used in medical education?
Well, I think, to take a broader view of that, besides narrative medicine in isolation, I think that there is a much greater focus on teaching specific communication skills, which are critical, of course, and overlap quite a bit with the skills you learn in narrative medicine. And so there's more small group teaching, lectures, and even simulation labs, model encounters, and role play. There's a lot of use of standardized patients or actual patient volunteers, in which you learn to get at least a medical story, right? And then we observe students and residents actually performing exams and interviews. So usually they report back to us what they've seen and heard, but we periodically, as part of their evaluations, we observe them directly. So that I think is a definitely a difference, and there has been
Just to jump in, as opposed to
sure.
in the past, what I get you were mentioning more of observing them in person and seeing what's going on to contrast to maybe 10, 20 years ago. How was that different before?
Well, you were definitely thrown into the deep end. I mean, there was an old maxim that described medical education as see one, do one, teach one.
Mm-hmm.
You know, you watch it, you have to go in and do it by yourself, and then you're supposed to show somebody else how to do it.
Mm-hmm.
And that, you know, so that it was much less direct observation of how you were conducting yourself in the patient encounter.
Mm-hmm.
And really less explicit instruction about sometimes about specific elements of whatever it was. I
Mm-hmm.
mean, for invasive procedures, obviously you'd be supervised when you did it,
Mm-hmm.
but I had never, you know, I had somebody just put me behind a patient and talk me through the steps of a lumbar puncture in the emergency room as if they were explaining to the patient.
Mm-hmm.
I mean, I'd never even seen one done before. And say,
Wow.
okay, now you're going to feel something cold as we put the antiseptic on your back, and then he'd sort of point to where I was supposed to go.
Mm-hmm.
So
It's
it was
like
quite
in
different.
action teaching
Yeah, yeah,
in the
yeah. I mean,
moment.
yeah, you definitely
Yeah.
remember it, but yeah. But there's also been a wide acceptance, certainly of medical humanities in
Mm-hmm.
the curricula, mostly undergraduate medical education, not so much graduate, you know, residency training. But somebody did a survey of all the medical colleges in the American Association of Medical Colleges, and most of them answered, you know, 70 to 80% had some form of either required or elective medical humanities. And it was
Mm-hmm.
more medical humanities, but writing was certainly represented. So I think that there is this recognition and acceptance of the role of the arts in helping enlarge our understanding of the meaning of illness for patients.
Mm-hmm. Definitely. And I think hopefully that'll only continue to increase over the years. And so far, I'm sure you can attest it's a great tool to have in your toolbox. I want to shift a bit to chronic conditions, another area that's I feel like I see so many news articles and opinions about like underdiagnosis and misdiagnosis. So I want to zoom in on that for a second. According to the CDC, about 6 out of 10 Americans have one chronic disease, and 4 out of 10 have 2 or more. And so a portion of these individuals, of course, are not yet diagnosed and maybe struggling to get diagnosed. Sometimes they have nonspecific symptoms or things that are varied, so one day it's like this, and then one day it's completely different. And so, as it relates to the delays in diagnosis for chronic conditions or even misdiagnosis, for conditions like fibromyalgia or endometriosis, which are, again, kind of these more varied conditions, what role do you think narrative medicine can provide in surfacing these hidden stories?
That's an excellent question. I think one of the things that I learned by when I did do observed exams,
Mm-hmm.
as you know, a clinician with more experience than the trainee I was watching, I would watch them, I'd listen to the interview, and the patient would bring something up, and I was like, oh, they really need to dig into that. I suspect that's key to what's going on here.
Mm-hmm.
And they would just walk right by it and keep going down their list of questions. I was stunned by that, and that's really kind of gotten one of the things that kind of prompted me to look more closely at a different way of teaching some of
Mm-hmm.
these things. So that's one aspect to it. The other aspect is sometimes framed as a cognitive issue, but I think a narrative framework actually fits it better. Is don't try to force things into a certain narrative, and and particularly for things that we can't see, like on
Mm-hmm.
an X-ray or less concrete problems, there can be a tendency to just assume that it's part of a certain narrative.
Mm-hmm.
And that narrative may be that it's nothing serious, it's just someone with a low pain threshold or something of that sort. And we have examples of that type of thing. But also, if your mind is going down one direction, and you think you're worried, you're trying to make a case for appendicitis,
Mm-hmm.
and really you're dealing with a different source of abdominal pain or poorly defined lower body pain, that you're going to miss clues, and there might be a piece that doesn't fit that you don't jump on, that maybe the person throws in something about uterine bleeding. Well, it's a woman, and it may be more endometriosis, just to go to
Mm-hmm.
that example. And if you got your mind just in down one track,
Mm-hmm.
uh, then you might miss that. So trying to collect as much information as you can before you create a narrative rather than prematurely foreclosing other narratives,
Sure.
even in a diagnostic setting, can be helpful.
Yeah, there's so much good stuff in what you just said. I think that idea you mentioned, like, I think they're going to hopefully ask more questions about this. Do you remember when that experience happened? Was it like a nonverbal cue or like the way they looked or how they talked? What was that? What was it that really jumped out to you?
I think it could be, a lot of it is just curiosity. It was something, it was often something that didn't make sense. And that's what, that didn't fit. So like, we walk in and we think we're dealing with X, and then something else was presented. And so sometimes it's just maintaining curiosity. Sort of like, I wonder what that is. Or that doesn't make sense. If we're dealing with X, we should explore that more. That would probably be the best way that I could describe it. But sometimes there are other cues about that, something that's worrying the patient, and they don't always know that it belongs in their narrative because they don't know what what symptoms they're supposed to have, right? Necessarily. But they might say, oh, well, it's probably nothing, doc, but there is one other thing that I've noticed, or something in an aside, or the last thing they say before they leave, the thing they're really the most frightened about. So there's some dynamics in how they present it that might make you pick up your ears. But the example I gave was more sort of, I wonder what that's about.
Yeah, and like you said, you don't know how the patient is thinking through what they're saying. It could be something they've like been building up courage to say, and then they were about to leave, and they finally got it out, and you never know like what's going on inside of their brain. So it's good to, acknowledge everything as best you can in whatever way that looks like. And so I want to move a little bit to the neuroscience of storytelling. So we've kind of laid out narrative medicine, explored that, and what that looks like. But let's see how it actually happens in the brain. And so I'm going to share a few key players, if you will, in the brain that are involved in storytelling and processing. And then I want to get your take on a couple of things as well. So the first area is the default mode network. And this is an interconnected network of brain regions that are responsible for internal processing. So things that are to deal with the self and kind of thinking through different things. Next area is Broca's and Wernicke's area. So those are two separate, sort of related brain areas. And Broca's is more focused on forming the sentences and language and sentence structure, while Wernicke's is how you receive that, so processing language. And the next area is the amygdala and anterior cingulate cortex. So these are pretty interconnected, both focused on emotions. Amygdala is more of the like raw emotions that you feel, and emotional engagement comes more from the anterior cingulate cortex. So that's when you're able to maybe be more interested in certain high energy aspects of a story. And then one of the last areas I want to talk about was the temporoparietal junction. So that's a really interesting area that helps us have theory of mind. And that's the idea of understanding how others feel and being able to put yourself in their shoes. And then, of course, hippocampus is involved in memory, and you can imagine how understanding a story and kind of connecting to your own experiences might be important in storytelling. And so my question for you, Dr. Harrison, is how are these areas in the brain working together, and what do they do to make narratives powerful? And also, how do we understand stories through the interconnectedness of these areas?
Okay, well, that is really a pretty new area of research, specifically at that. But obviously, in neurology, there's a long history that's identified. So originally, it was really through looking at pathologic correlations of certain symptoms. So if you had a stroke in a certain area, you couldn't understand, your Wernicke's area was affected. If you had a stroke in a different area, you couldn't produce language, and there were variations in between. So it was very much lesion-based, and that's what neurologists often focus on, is quote, localizing what part of the brain is involved that's giving us the symptom, lesion localization. And that's still an important tool for neurologists.
Sure.
But the technique of functional MRI that looks at oxygen signal, and that reflects blood flow to areas of the brain, that correlates with the activity in the areas. And so that began to shed light on understanding symptoms that were really related to disturbances in the function of the brain and different areas in these interconnected networks that we'd identified through neuropathology. So even if there's no obvious spot that you can see, or scar in the brain, if you will, that you can see, and so that it was more in a clinical context, right? And so we knew from neuropathology, for example, that there's a specific circuit that connects the Wernicke's and the Broca's area. And if those two areas are intact, but the circuit's interrupted by a stroke, then there's a different set of symptoms. So we knew the pathways, but what we didn't have the ability to do was see them work together in real time. And so those connections between memories and emotions, for example, the limbic circuitry we were aware of, but now we can see that they have roles, maybe wider roles. And so the other really interesting thing is that in the last few years, functional MRI is now being used to investigate subjective experiences, like experiences and responses to stories. And that's been an active area of investigation. And so the default network for sure participates in story processing. Particularly, they describe it as self-related processing, introspection, if you want to think of it that way. Think about your own thoughts and feelings and experiences. And then there's another area that they have also identified, which is called the anterior insula, and that's an area that conveys information from your autonomic nervous system about heart rate, breathing, that kind of thing, upstream, and to be available to the brain to help assess what's going on, and that also is related to decoding your subjective experience of emotion. If you're afraid, obviously your heart's racing, might be other reasons, but and so people are starting to say, well, how are stories experienced and understood using functional MRI? And it turns out these two reasons are important for that. So there was just a study that caught my eye as we were talking about having this conversation, in which they wanted to look at these two areas and how their functional connectivity with the rest of the brain was affected in processing narratives, and how consistently were they involved in processing narratives, if this makes sense. And so they used two types of stories. One was a narrative about cancer, someone with a cancer diagnosis, and one was two hitchhikers who get picked up by a bad actor and get away. So very different, action story, and then more of a human drama of a different type.
Of course.
And that one area in the posterior medial cortex was involved with both of them, and that seems to be consistent across other studies. But the involvement of the other area was different depending on which story it was. It wasn't a universal that getting the sort of physiologic readout of your emotions, and it was not surprisingly higher in the hitchhiker story, where they had to get away from this guy,
Sure.
and also the motor cortex lit up in that story. And so we know from other early functional MRI studies, if you think about walking, your motor cortex lights up with increased activity. So that recruited a specific content-related area, if you will. So it's fascinating stuff. I think it's really just at the beginnings of our ability to understand these things. But that's one example.
Definitely. Yeah, interesting. I think if you look at it in some sense, everything around us is really a narrative, is a story. So it's interesting to think how in these studies how we process different things, but then also one day maybe we can understand how we process every single thing that we go about seeing in a day. So I want to switch a little bit to outside of the clinic, how narrative medicine comes into play. Of course, we've talked about narrative medicine is rooted in healthcare, and that's kind of what it was created to do, to be able to connect better with patients and for patients to connect better with clinicians. But these ideas can definitely be used outside of the clinic. And so I had a question for you. How can principles like what we've talked about, close reading, deep observation, this idea of narrative understanding, how can they enrich our life every day and how we connect with those around us?
Okay. I think, that's something that I have thought about, certainly. And I think there's really two levels on which that can happen. One is in our individual lives, and really the practices we use in engaging with others. And I think that that there's a lot to be gained by reflecting on things with reflective writing, but particularly close listening. And here I would make a shout out for put down the phone. You know, really being engaged when you're communicating with people, and so you pick up those kinds of cues. And so I think that, and then perspective taking, really recognizing in your encounters with others what are the narratives that are operating. Are you really talking about the same thing? And that's certainly something that's important in medical communication, is important in our personal relationships. And so I think that is a really valuable skill, which is really taking the time to think about what's the other person's point of view, and that perspective taking theory of mind idea. And there was actually a wonderful video from a healthcare setting that was made by the Cleveland Clinic, and it's known as the empathy video.
Okay.
And it basically shows people walking around the hospital, and shows you they don't have thought bubbles, but it has a voiceover of what they're thinking. So you see a guy, and maybe he pushes past somebody, gets on the escalator. And then in the voiceover is he's rushing to the ICU because his relative has taken a critical turn for the worse. So, and it gives many, many really moving examples like that. And then it's just, the end is just, if you knew what they were thinking, would you see them differently, or would you treat them differently? Like, rather than be ticked off because the guy pushed you aside to get up on the escalator, if you knew he was rushing to the bedside. So that's not restricted to narrative medicine, but it is that perspective taking and recognizing that everybody has a story, and that not to rush to judgment, to maintain, an openness about that. And that, I think that there's a related concept really of, taking it from the individual level to the higher level of what's happening on larger scales, and how does narrative relate to that, which we could get into if we have a little bit more time for that question.
Sure, yeah. And that idea of zooming out and being able to think about what someone else may be going through, I think is very important. And I have a follow-up question to that. So how would you say we can use these skills, and what specific tricks, I guess, do you have for dealing with hard conversations, conflict in communication, whether that be in workplace disagreements, family conversations, or even in politics, which is rampant in these days?
Okay, well, actually, that is sort of where I was headed. So
Okay,
we're on the same page with that. I think again, that open-ended curiosity and not immediately going to judgment, making a judgment about a situation. But I think that there's a larger context in which we can understand how narratives are operating at each of these levels beyond the individual level. And I think that's something that Arthur Frank has written about, as well as these illness narratives. And and there's a couple of important things to recognize, is that there are narratives operating on the cultural scale, on the social scale, and they can be constructive, promote positive outcomes, or they can be destructive. And othering would be a pretty good example that of something that allows a negative narrative to develop. And narratives define common values, and people use them to identify a group. I'm the kind of person, I'm like these other people, and this is our story, right? Yeah. And I don't think it takes much imagination to see that some of that's going on currently, and in the societal level. And so I think if you don't recognize that, then I think then you don't have effective ways to try to open the conversation up beyond those closed narratives. But it does influence what people see the possibilities are for themselves, and constrains what they think their options are. So they can be, even a good narrative could be limiting in that way. And so I think that there are So there are strategies. People are using these for conflict resolution. Palliative care has tactics for that, and really, recognizing and acknowledging the emotion in the room, naming it, and non-judgmentally.
Mm-hmm.
But I think that there is actually a program to train leaders of like cities or larger political entities in using narrative techniques to become more effective leaders.
Mm-hmm.
There's probably more than one program, but the one I'm familiar with is at the Harvard Kennedy School of Government.
Uh-huh.
And it was actually developed by a fellow who spent years organizing. He was a political organizer with Cesar Chavez and the United Farm
Oh,
Workers and with
wow.
some civil rights organizations.
Mm-hmm.
And Pete Buttigieg actually took this class.
Mm-hmm.
And so the strategy is you have to understand your own story and why these things matter to you. And then you have to help other people find their own stories, and then you have to find a way to bring those together. So it's I think a potentially very powerful tool. Or if you think even about the recent Democratic primary for New York mayor,
Mm-hmm.
that young man was out and just asking people questions about what was important to them and why they thought that and what had happened to them to make it be important to them. He
Mm-hmm.
just listened to their stories. So there's a role for these tools in other settings, I think.
Mm-hmm. Definitely. And that's the way you say it sounds so simple. Let's just listen to others. But what tips do you have for people when they're so emotionally invested in things and it's hard not to these days? So how do you recommend people put their emotions not to the side, but maybe tone them down a little bit and really have a meaningful conversation and
Mm-hmm.
try to exchange perspectives, as you said?
Well, I think really going back to that, because there's such a correspondence between, I think the communication skills in palliative care and
Mm-hmm.
end of life care, which is certainly an emotion provoking setting, right?
Sure.
It's more, within a family, for example,
Uh-huh.
it can generate conflict. And I think there are two strategies, because we did some work in that area as well with in a clinical setting, but there's two strategies I think that stuck with me from learning about those approaches. One was name the emotion.
Mm-hmm.
Sounds like you're pretty angry. Um, and then the second is ask permission. Could we talk about that?
Mm-hmm.
I'd like to understand that better. Could we talk about that? Um, and in a palliative care setting, it may be I don't want hospice because they just stopped all the meds and put my mom on morphine and she was dead in 3 days. That's um, in a political setting, it would be something different.
Mm-hmm.
Um, uh, Different kind of conversation. But I think naming the emotion, controlling your own emotions, obviously, that's not the easiest thing to do. But I think sort of like calling a timeout. I think this is really important. Can we take a minute to talk about this? It sounds to me like you're angry. Can we
Mm-hmm.
unpack that? And
Yeah.
asking the permission, I think, is also very respectful. Maybe the person is like, no, I don't want to talk to anybody like you because I already know what you think and I'm
Mm-hmm.
against you. You might not be able to get the conversation started.
Sure. No, that's a great tip. That way you kind of state what you are noticing and then ask for permission to explore if that's okay. And again, as you said, sometimes people, for whatever reason, may not be interested in that. So it's
Right.
it's good to lay that out before you jump in. Hmm. Yeah. So I think we're kind of approaching the end, and I want to go back to the personal side and your experience with stories and narratives as well. So, what's a story that has changed the way that you understand yourself or the world or even your patients?
Well, that's a really interesting question, and there are stories that I kind of go back to from
Mm-hmm.
different eras of my life when I was becoming aware of what was going on around me more. And and so if I was going to pick a story that changed the way I understood myself in or the context in which I understood myself, I guess,
Mm-hmm.
and taught me something about the world, it would have been the civil rights movement, I would say, actually, because I was in high school when Martin Luther King was assassinated, and I grew up with a certain narrative being presented to me on television and
Mm-hmm.
pictures in Life magazine of all the violence that
Sure.
around the efforts to desegregate the South. And the examples of people like Martin Luther King or Rosa Parks, who wouldn't give up her seat, or John Lewis at Selma, they were changing the narrative in front of our eyes. They were being met with this tremendous violence and hatred. And they just stood firm where they were and didn't react with violence. And that, I think that's, to me, a very profound example of changing the narrative. And so I think that, and there's a story there. It's certainly quite the storyline. And along over many, many years. So I think that's the example that I come back to a lot in my own thinking.
Yeah, that's very powerful. I think it's great to look back in history to get inspiration, and then also sometimes in other cases to be wary of certain things. So kind of wrapping up, you mentioned a lot of practices that people can use, that you use and others in the medical community use, like close reading. What are some skills or some practices that you would recommend for someone who's interested in learning more about narrative medicine? And for example, in this scenario, let's say they're not in the medical space, they're just an average person looking to have better communication, better conversations with those around them. What would you suggest?
Well, for one thing, you don't have to necessarily be a doctor or a healthcare worker to get some training in narrative medicine. So certainly, what was very influential for me in going forward with this was I think writing and reflection is always a good tool. Journaling. I mean, those are things anyone can do that can be applied in so many different ways. And as a doctor, I heard so many stories that, and they stuck with me, and I started writing those down. And I became aware of narrative medicine. I don't really remember exactly how I first heard about it, but I think if you experience it, it's quite powerful. And so, if someone really wanted to learn more about narrative medicine, I think you can do a workshop, and there are some virtual workshops, but they have weekend workshops at Columbia, and they have online things that are focused on specific areas. You can do them as part of a degree program, or just things that you're interested in, maybe to get a certificate. So, and then those are some very specific to narrative medicine. And then I think we've touched on some of the others, things like mindfulness. The perspective taking, some of those interpersonal techniques. But it's helpful to have models and to practice. And so certainly often there's role playing in settings that are teaching communication skills. But any approach to communication skills, I think, will start to take you into the same territory, and reflection and self-reflection.
Sure. Yeah, and I know in a few conversations we also mentioned the idea of art. So art analysis, poetry, and again, just deep observation of different things around you. And that can also help, of course. And can you share a little bit more about what you found valuable in more of the art side of things? So being able to understand artwork.
Oh, sure. Yeah. After I got interested in narrative medicine, well, they didn't have an online program at Columbia, but they did an experiment for a year with some of the faculty, and Arthur Frank participated in that, which was quite a privilege to work with him.
Wow.
And it was a distance learning type thing, like 1 week each semester. We were in person, and then we had synchronous Zoom talks and exercises in between. And that was actually specifically described as narrative practice. And we had everybody from a rock and roll musician to a cartoonist to a dancer, to actors, leading different exercises, as well as each semester reading a pretty complicated literary work and doing classical kinds of narrative medicine deconstructions of different areas of it. There was actually a medical student who was interested in the dance, who did a presentation in this week's medical education seminars of a project looking at dance. So, and there's a dance for Parkinson's movement. So there's many ways that other forms of the arts can access this, but some of the best established are the visual thinking skills. And so we actually incorporated that into the curriculum that I developed, that with the help of the education curator, who she worked with somebody in the medical humanities, Center for Biomedical Ethics and Humanities in the medical school, to develop a visual thinking skills exercise for medical students.
Okay.
And so she brought that to the residents. And so it's really doing a visual inventory of an artwork. Mm-hmm. And then there's a series of really interesting exercises that they do with that, but it's just sort of, what do you see? And the first lesson is, you don't all see the same thing. So it's like, oh, right, there was that big blue thing up in the right-hand corner. I didn't even notice that.
Yeah.
But then also ways of trying to explain what you're seeing to other people. She would have someone dictate what they were seeing, and someone else who couldn't see it would try to draw it, for example. And I mean, it's just very, very interesting exercises. But many, many museums have programs like that. Mm-hmm. And they have them for patients as well. There was a program that started, I think, in a museum in New York City, in Spanish Harlem, for patients with dementia who may not have good verbal communication but can still react to things. So there's many other applications in other arts, and there's someone at Penn State University who works with music, and listening to music, and then doing exercises around that. Mm-hmm. So I think there's a lot of really, really interesting possibilities that can be used both for one's own enrichment, but also in an educational way.
Of course. Yeah. And I think the list is endless when it comes to techniques and everything. So it's definitely a lot to get into. And so kind of knowing that, my last question for you is, if someone is listening to this episode, what is one thing that you want them to take away from it?
That's a great
easy question. I know.
Yeah. One thing, I have to just pick one. I think learn to listen. That would be my message. I think if you start there and learn to listen and suspend judgment.
Mm-hmm. All right.
And be curious.
Uh-huh. Wow. All right. Well, that's something to learn. That's a great point. Dr. Harrison, thank you so much for joining us today. This was a very thoughtful conversation, and I really loved learning more about narratives and how really the average person can use ideas of narrative medicine to hopefully connect better with others, and the idea that everyone is human no matter what they might do, and of course just learning from others and being able to have some grace in different situations. So thank you so much.
Thank you for having me, and I really enjoyed our conversation.
And to our listeners, please come back next time and learn more about deep dives into the brain, mind, and beyond.